Dr. Marko Popovic is a retinal surgeon, a retina specialist, and he's assistant professor at the Department of Ophthalmology and Vision Sciences at the University of Toronto. Dr. Popovic, thank you very much for being here.
I'm truly honored to be here and just witness the collective patients in our clinics, residents and trainees, doctors, industry partners, other vision health stakeholders. Like, it's truly remarkable to see this group of individuals all come together in a symposium like this. And I really want to thank Vision Health Canada, Keith Gordon, Michael Belarjan, Jim Hall, everyone that works tirelessly behind the scenes to make an event like this successful. And so thank you so much for all the incredible work that you've done, and I look forward to many events like this in the future. So my talk today is on the topic of geographic atrophy, which is, as Brendan was saying, it's kind of one variant of an aggressive form of macular degeneration. And to be honest with you, if I gave this talk 5 or 10 years ago, there wouldn't be actually very much for me to say, because this has somewhat been kind of a forgotten cousin of macular degeneration. The other form, the neovascular or the wet macular degeneration, has received much more attention because we have all these effective new therapies, the anti-VEGF drugs, that have really revolutionized our care for patients with the condition. But geographic atrophy, unfortunately, has been a condition that has not received as much attention until much more recently. So I hope to go into kind of some of the new advances in the field of geographic atrophy and some of the emerging treatments that may be realizable in the near future. So I won't go over, an entire background, because I think Brendan summarized beautifully about age-related macular degeneration. We know that it's the most common cause of vision loss in the developed world in those age 50 and older, and different risk factors obviously include increased age, but also, smoking, blood pressure, obesity, low levels of physical activity, various other factors, including family history, that play a role in this condition. And I think Brendan, demonstrated a similar slide, just looking at how we look at the retina. This is a copy of a normal retina, where you see here the optic disc, which is the cable that connects the eye to the brain, and then beside it is this area called the macula, and the center part of the macula is the fovea. This is all responsible for your very fine color vision, and fine visual acuity that you use for most of your visual needs during the day. And so this central part of the retina, termed the macula, is really where this condition of age-related macular degeneration happens. And so this is an example of a patient with a more early form of macular degeneration that has not progressed into neovascular or wet AMD or geographic atrophy. So this is just characterized by the presence of drusen, those small little lipid and protein deposits that Brendan summarized so nicely. And so again, a slide summarizing the progression from a normal retina to the development of drusen, so the early form of macular degeneration. And then it can really branch off into one of two pathways, which we've already discussed about, either geographic atrophy, where there's actually loss of tissue and loss of photoreceptors, or the wet form of the macular degeneration, where there's new blood vessels that form and cause leakage and bleeding and complications as a result of that. This is an example of an image. This is called a fundus autofluorescence image, an image that we commonly use in the clinic to assess the progression of these geographic atrophy lesions over time. And so you could see in this patient who has multiple areas of discrete geographic atrophy, they're those kind of very dark little spots that are kind of innumerable around the center of the fovea. You see over time, by year 3 and year 5, how they grow in size. And so this is an example of an imaging modality that we use in clinic regularly to assess the progression of these geographic atrophy lesions over time. This is an example of a patient where you see in the dead center, their fovea has not yet been affected by the geographic atrophy lesion. So this is a patient who may still retain fairly reasonable vision, but as you see, as those lesions continue to grow over time, they may lose significant vision if their fovea becomes involved, and I'll show you pictures of that as well. So this is another now color photo of the retina, where you see the geographic atrophy lesion, which envelops and circles the fovea. But in this case, that fovea, the center part in this patient, is still maintained. So the patient is still able to retain fairly reasonable vision. They might, for example, complain of loss of the visual field in a part of the vision that's outside of the dead center, but in terms of their general visual function, they may be able to retain reasonable visual function. So that's now in contrast to when geographic atrophy, the condition is advanced and it starts to envelop the fovea. So these are other different imaging modalities that we can use in the clinic to showcase how this patch of geographic atrophy has now gone over the center part of the retina, over the fovea, and this patient is likely to have very poor central vision and poor visual function as a result. And so just tying it back to the patient perspective, because that's something, within the context of this forum that is tremendously important, and I'm so honored to have some of our patients here today to, share some of their stories and experiences with the disease. What are the functional implications? Well, different patients really report different things, and you could see in the, in the normal image in the bottom left, as the image is supposed to be interpreted, a few different, depending on the stage of disease and what disease it is, a few different manifestations can happen. So there could be a darkening or a loss of the visual field in the dead center, where you see a black area in the dead center, as you see in the top left. The colors themselves can be kind of more washed out, as you see in the top right. Like straight lines can start to appear more wavy, as you see in the bottom image, or there can be a general perception that the vision is more dim than the patient is used to, as you see on the bottom right. So these are all, depending on the exact disease, these are all different possible manifestations that can happen from the patient's perspective. And so that's, in a quick way, just to summarize macular degeneration, the wet form and the dry form, and now geographic atrophy. What I'd really like to focus on today in a little bit more detail is some of these new emerging treatments for geographic atrophy, which are novel and have really the potential to change our clinical practice. I'll start off at a very foundational level to say, what is it, if someone presents with us with geographic atrophy, what is it that we do in the clinic very practically? So patients with macular degeneration, one of the things that we tell them to do is to use what's called an Amsler grid. And so you see an image of this represented here, which is basically a checkerboard grid with straight lines. Now, those lines can start becoming distorted with the progression of this disease. And so we ask patients at home, they can monitor this grid. They could put it on their fridge or wherever in their home, and periodically monitor the Amsler grid to see whether those distortions evolve over time. And that's really a nice kind of screening test that allows us, if the lines are becoming more distorted over time, it allows us to, for the patient to call into clinic, to be rebooked for an appointment to see if there's been any anatomic or structural progression of their disease. Different lifestyle remedies, obviously just eating well, eating a well-balanced diet. Leafy green vegetables are very important. Protecting the eyes from sunlight is another very, very important thing. Patients who are smokers, we do advise them to stop smoking, because all of these things really play a role in the progression of this condition. And then there are, of course, the AREDS 2 vitamins. So you may see different brand names, Preservision or Vitalux. These are common vitamins given to patients who have the earlier form of macular degeneration, the dry form with those little drusen yellow deposits, which is very good and has robust research that has shown that the condition progresses less frequently to the more advanced form if these vitamins are used. And then, of course, I won't go into a lot of detail about the wet form of macular degeneration, but this is, over the last 10 or 15 years, really been a huge paradigm shift in our clinic, taking something which has been a very poorly treatable condition into something that is much more readily managed with the use of these injections that are delivered into the eye of a medication called the anti-VEGF medication to reduce leakage, bleeding in patients who have these new blood vessels that are growing from the wet form of macular degeneration. And I won't go into the whole history of everything that's happened in the field of wet macular degeneration, but more to give you a summary to show, over the last 20 or so years, there's been a tremendous amount of innovation and advances. many new companies coming up with new products, showing well-designed research on new agents. The kind of more recent agents that we have an even longer lifespan or durability, so that it allows us to really treat our patients with less frequency of treatment. And so there have been a tremendous number of agents that we use day to day in our practice that really didn't exist 2 decades ago. And when I compare that again to geographic atrophy, if I gave this talk a few years ago, there wouldn't be much else to say because there wasn't really any other treatment that's available. But I hope to share with you some of the advances that are happening. The first is a very simple one, and it's something that we have access to already, which is those vitamins, the AREDS2 vitamins that we discussed before. And this was a paper that came out just last year in 2025 that was basically one of the first main research studies to look at whether the vitamins at all make a difference in patients who have geographic atrophy. And I think you'll find that the findings are pretty interesting. So, this was based on the original trials which looked at patients with the earlier form of macular degeneration. Some of them, of course, developed geographic atrophy, and we wanted to now look back to see whether there was a difference in those who used the vitamins versus those who did not in terms of how much geographic atrophy actually developed. And so to study this question, they looked at 2 main outcomes. The first was, were the lesions growing in size? Just a general kind of area of the lesions to see whether they were growing. And the second looked at the location, because as we know, location is so important in this disease. If the disease starts to involve the fovea, that's really where a significant loss of visual function can happen. And so they looked at whether the lesions have a higher or lower tendency to grow towards the center of the retina with the use of these vitamins over time. And so these numbers basically showcase that while the actual size of the lesions did not change over time, the growth towards the center of the retina actually improved. So there was a slower growth towards the center of the retina in patients who used the vitamins. And that was really the first time that we as retina specialists received this type of information to say that not only can we use these vitamins in patients who have the earlier form of macular degeneration, but we also might be able to use it in a more advanced form, i.e. this geographic atrophy, to prevent the growth of the geographic atrophy from entering into the center part of the vision. So I think this really helped us, to rethink about how to use, these eye vitamins in our day-to-day practice. And so we know that the vitamins, they don't prevent the loss of existing geographic atrophy lesions, but they can help prevent progression of the new lesions over time. And so the next treatment I want to go into is another injection-based treatment, similar to how the current wet macular degeneration drugs are injected into the eye. These new treatments are also injected into the eye. They're based on this system, what's something called the complement inhibition. And so that's just a fancy way to say it's based on the body's immune cells. So we think that macular degeneration is in and of itself an immune-related condition. And so if we can somehow block the specific immune targets that are leading to the development of geographic atrophy, we may be able to halt or prevent the progression of this disease. And so that's really the rationale for why we would consider inhibiting these complement, these immune markers. And so this is a pathway of the normal kind of immune cells in the complement cascade. There are different markers that are involved, including C3 and C5, and different medications have been developed to actually target different parts along this pathway to prevent that immune response and to prevent the growth of the geographic atrophy lesions. Similar to what we talked about with the vitamins, these medications are not there to reverse the growth of atrophy lesions that have already occurred, but they're more there to prevent further vision loss. And so now good studies have been designed where they've compared patients who receive these eye injections that have inhibited the immune cascade versus those who did not, and actually found interesting results. And I hope to share 2 of these studies here. The first is for a medication called pegcetacoplan, which is one of the markers that is targeted by this medication. And so they, again, randomized patients. They randomly assigned patients to either receive the medication or to not receive the medication. Overall, they did 2 big studies, recruiting about 600 or so eyes into these studies. And so I just want to show you the graphs here. The numbers are less important, but if you see here on the left-hand side, the patients who received no treatment were the gray line, so you see the growth of their lesions over time. And then the patients who received the actual treatment, they received it either every month or every other month. That's the blue and the red line. You see a difference between the 2 sets of lines. This is an analysis that goes up to 24 months of treatment, so about 2 years of treatments. And you see, at the beginning, maybe month 6, there's not really a huge difference between the 2 groups. By month 12, there starts to be a little bit of a difference. By month 18, there's even more of a difference. And by month 24, there's quite a bit of difference, And so numerically, there's about anywhere from a 14 to 16% reduction in the growth of these lesions over time. Now, with these short-term studies, when we look at month 24, the visual acuity, or the amount of vision that the patient had, didn't really change, because many of these lesions were outside of the visual center, and so even though the lesions were able to not grow as fast, they didn't necessarily improve the vision in this limited study. But now, as we get more and more data over time, now we look into month 36, there are new markers which are showing us that potentially there may actually be a visual benefit when you give these medications over a prolonged period of time. The analogy I like to think of is that if you take a boat and it's going from Europe, or it's going from, the UK, and it's sailing, towards North America, if you, at the beginning of that trip, if you change the degrees of that boat just a few degrees over, and then you see what the position of the boat in its original position versus where it was changed, there might not be too much of a difference by a few days or a week. But if you then start looking kind of many weeks down the road, and when it eventually reaches the other continent, one boat may be in North America and the other boat may be in South America, right? So that's just an analogy to showcase this principle that, at the beginning, if you do 1 injection, 2 injections, 3 injections, there may not be a huge difference that patient would report to you. But if you look over the long period of time, over many, many years, if you continue with the treatment and you're persistent with the treatment, there really is potentially a benefit in terms of maintaining good vision in these patients with geographic atrophy. In terms of different side effects, obviously there are the side effects that any injection-based treatment would have, so risk of infection, risk of bleeding. Those risks are all, thankfully, very, very rare. This is a treatment that I in the clinic do many, many times a day, and thankfully the amount of time that I've actually seen infection or bleeding is extremely, extremely rare. There are, of course, those risks with any treatment, whether it's the existing drugs we give or these new medications. But one of the side effects that has been noted is that potentially these drugs may make the wet form of the macular degeneration slightly worse. So there were a few more patients who received the geographic atrophy agents who had a worsening of their wet macular degeneration. And so that's just something very important for us as clinicians to be aware about, so that we're monitoring for not only the dry form of the macular degeneration, but also the wet form of the macular degeneration, to make sure that doesn't get worse over time. Right now, this medication, which is called pegcetacoplan, has already been approved in the United States. So this is a medication that is commonly now being used in the United States. When I was, during my fellowship, when I was in my last year of training, I trained at the UCLA Center in Los Angeles, and we gave this medication commonly to patients. So, we do use it there in the United States. Unfortunately, it has not received approval for use either in Canada, so by Health Canada, or in Europe. And so it continues to be used primarily in the United States. I want to showcase another medication. This is another complex name of avacnacapnode pegol, which is, when I showed you that pathway of the immune pathway, this targets another part of that immune pathway. And so, similar type of idea, they compared patients receiving the medication to not receiving the medication to see how they did over many months. And so, many hundreds of patients were enrolled in these studies. And so, again, looking at first at a short-term basis. So when we look till month 12, again, the two lines. The blue line is those who did not receive the medication, and the red line is those who received the medication over up till month 12. And there was about a 14% difference in the growth of these lesions over time. But I think what's really much more powerful is then, again, when you extend this data out. And I want to thank Astellas for providing some of this kind of very recent data that looked at these studies and how patients did over many months over time. This analysis looked at up till month 42. And so, when you look at the early data, there's, again, maybe about a 15 to 20% benefit, but then when you start looking out further, there may be a much higher benefit, up to 30% of the benefit. And then when you look at patients who were started, for example, those who originally did not receive the drug, and then they received the drug after the study concluded in the 24th month, and then you looked up to the month 42, there was actually anywhere from a 37% to a 40% benefit in those patients who did not even receive the drug at the very beginning, suggesting that it's really a dose-dependent relationship. The more of the drug you give over time and the longer you wait, the more of a benefit that you're likely to experience. Again, in the early studies, when they looked at month 12, there was not really a difference when it came to the visual acuity as a marker. And so this medication now, the trade name is Izervay. This has again been used in the United States, and we have experience in the United States using it. And they are now, submitting their application to Health Canada, and so we are hoping that in the near future we'll have a decision from Health Canada as to whether we are, as retina specialists in this country, allowed to use this medication. And so that's kind of where we stand right now. If Health Canada then says, yes, we are allowed to use the medication, this is something that is likely going to be rolling out in clinics across the country, and at that point, obviously, there are going to be other questions as to, which are the appropriate geographic atrophy patients to treat, which might not be the appropriate patients to treat, and this is something that we as retina specialists in the community are going to have to reconcile, and it's something that we are already thinking about as we learn about these drugs in their kind of real-world use based on our colleagues in the United States. The drug also has been approved in other jurisdictions like Japan and Australia, and so over time we're seeing more and more of an uptake of these medications. I want to just also highlight a few other areas of treatments that are being investigated. The first is, well, we have all of these injectable treatments. There are now 2 that are being used in the United States. Could there be a medication that could be an oral pill so that you don't actually have to inject a medication in the eye? And one company called Belite Bio is actually looking at this concept to look at whether there could be a pill to treat patients with geographic atrophy. And this pill is based on regulating vitamin A. We know that vitamin A is very important. Its normal function is very important to have good vision, but vitamin A can cause some toxic byproducts and can sometimes be damaging to the retina if it's given in high amounts. And so this treatment by Belite Bio is actually looking at this question: could you actually change the vitamin A regulation to actually improve or reduce the progression of these geographic atrophy lesions? We don't right now have an answer to this question because this is right now the study is still being conducted, but it's something in the future hopefully we will have an answer to. It's interesting, they've also applied this treatment based on the vitamin A cycle to patients with Stargardt's disease, which is a condition which is an inherited retinal condition that previous to this didn't have any good treatments. And very recently, in December of last year, they provided good data showcasing that patients who had atrophy in the context of Stargardt's disease had a lower progression of their disease over time with this new oral pill. And so we're going to have to see whether the same conclusion applies to patients who have geographic atrophy. And so this then brings me to, okay, well, this is all good and great for patients who have these lesions outside of the center of their vision, but what do we do about the patients who have already lost their vision, patients who the geographic atrophy has already gone on to the fovea, and the patient, has poor visual function already? Astellas is developing a new stem cell-based treatment for this condition, where stem cells you could think of as kind of general purpose cells that can transform into all into different parts of cells from other different organs. Some can become skin, some can become heart tissue, some can become tissue in the retina. And so these specific stem cells that they're looking at, they're trying to program so that the stem cells try to develop more into normal retinal tissue. And actually, if you inject these stem cells into the eye, into the back of the eye, the goal is to see whether these stem cells can actually become viable retina tissue to help patients who have already lost their vision. Now, this is still in kind of early stages of experiments, and other teams have looked at this stem cell-based approach as well. But this is more just to let you know that there are groups out there that are working on different stem cell-based treatments that may one day, also impact the lives of patients who have already lost their vision from conditions like geographic atrophy. So overall, geographic atrophy is a sight-threatening condition, and it's insidious. It grows over time, and it eventually envelops the visual center, and it eventually impacts patients' functions. And right now, today, in Canada, we don't have any treatments, but I'm hopeful that we will, have treatments for this condition in the future, which can meaningfully, maintain good vision in patients over time. Different treatments that we discussed today are the 2 injection-based treatments that are already being used in the United States, one of which is potentially will be used in Canada if Health Canada grants that approval. But other treatments might include oral drugs, drugs by mouth, or these potential stem cell-based treatments, which is used in patients who have already lost their vision. And so I hope that these treatment options become a reality, but I think overall it's a very exciting time for us in the world of geographic atrophy. So thank you very much for your time and attention. And I'm happy to take any questions if anyone has.
I can just say there were a couple of questions that I received from people who were online, but their questions were completely answered in my mind by Dr. Popovic. They all dealt with emerging treatments. So thank you.
Any final questions? I think there may be a question there. Yes?
Often, when it just snaps out the art, also get him lives the lines or results in the areas. I have a question about lots of AMD, but talking about the costs and injections and vitamins available out there here in Canada, are they covered by government?
Yes, so that's a very good question in terms of the cost of the various medications. So we're very lucky in Canada. So I'll just give you an anecdote from my time in the United States, where I treated patients in the United States who did not have good health insurance. And, it was a very unfortunate situation sometimes because you knew what the condition was, even if it was conditions like macular degeneration. You knew what to do. You had the injections available to you. But unfortunately, sometimes I could not give the right patient the right treatments because of these issues exactly in terms of health insurance. So I really just want to contrast that to our state in Canada, where I feel, the coverage that we have for some of these treatments is much more well developed. And so we as retina specialists, I think, are very lucky, and as Canadians are very lucky to have many of these treatments covered. Now, it's not covered in absolutely every case. So for just talking now about wet macular degeneration, the therapies, if you're over 65, you have macular degeneration, it'll be covered by the government. Patients, for example, who might be younger or might have diabetes in the eye or other situations, they might not have, an automatic coverage by the government, but if they have other programs like Trillium and other things, they may be covered. So it's kind of more of a case-by-case basis. In terms of some of these new medications that are coming in for the treatment of geographic atrophy, the thought is that if they receive approval by Health Canada, then there will be a discussion with the government as to what the price of the medications is going to be exactly. And our hope is that they will be covered as well for patients in the demographic of macular degeneration, which, as we know, affects those over 65 typically. So we hope to have the treatment, approved hopefully and hopefully covered as well. Yes, there was a question at the back.
Thanks very much for that nice talk. Milton Charlton, I'm wondering why hasn't Health Canada approved the C3 or C5 inhibitors? Have these other papers come out so recently that they have not considered the long-term studies, or what's the deal?
So that's the thing. I think as we gain more information over time, it provides a stronger and more compelling argument to those in Health Canada to approve the treatments. The problem is, so here's the problem. So in the United States, the FDA, which is the regulator there, said that you can use those graphs that I showed you, the change in the geographic atrophy lesion over time, that was an acceptable kind of outcome to look at. So if you improve that outcome, that they would grant an approval. So they've already kind of been very clear with that. And so then when they showed that there was a difference, they were able to receive that approval in the United States. But because these are some of the first medications that were even approved in the United States, not all regulators like Health Canada or others in Europe or whatnot necessarily kind of prearranged that to be the outcome of choice. And so I think right now there are probably internal discussions with Health Canada as to, whether the data that I've just shown you, whether it's sufficient enough to justify the approval or whether, the companies need to provide further data. My personal take on it is that, I would prefer for the medications to be approved so that retina specialists actually had a chance to use it. And then I think that medications would be best suited in the retina specialist's hands, because then they would see which of their patients are appropriate candidates and which patients may not be appropriate candidates. And then, you provide the onus of the treatment, of the burden of treatment on the retina specialist to decide, which patient is an appropriate candidate. I feel like that's a much more kind of nuanced and a better approach than just to say, it should not be approved, no one should receive it at all, So, but this is an ongoing discussion. I'm not, 100% sure that they're going to approve it. We're going to have to see what happens. But as time has gone on, as I said, more and more jurisdictions, more recently Japan and Australia, have approved one of the medications, and so we are kind of gathering more approvals over time. But we'll have to see whether that translates to Canada as well.
Thank you very much, Dr. Popovic.
Thank you.
Mm.